This morning, I'm pleased to have Dr. Humphries.
Thank you. If there is one thing that I have less and less of, it is time. And within that time that seems to be shrinking, I am continuously asked to do more and more. And while I am still mastering the art of saying no, which I'm sure many of you have heard about and we talk about frequently, one area where I frequently cannot say no is when it comes to patient care. And so that is what I'm going to talk about today. I have no financial disclosures related to this talk, but this talk is going to focus on empathy. And myself and a few other people in this room were selected to go to a empathy sponsored course by UCDAVIS. Mike Campbell, Muhammad Ali were there. I don't know if anybody else was there. We went on different days. And so what I talk about today came from that course and some of the tips and tricks that we learned there. I drink a lot of different types of Kool-Aid, and this may not be your type. And if it's not, that's okay. But hopefully I can give you one tip or trick or something that you can do in your clinic to improve your patient care and also to improve patient satisfaction and improve outcomes. So we're going to start with a video, and some of you may have seen this before. How many of you have seen that video before? I like it. Luckily, I've seen it like a dozen times, so I don't cry anymore whenever I see it. But today what we're going to talk about is empathy. We're going to define it. We're going to contrast it with sympathy and pity. And we're going to discuss how empathy is intertwined with communication and how it shapes our patients' perceptions of care. We're going to discuss perceptions of care here at UCDAVIS as well as nationally. And then we're going to talk about a method that has been used to improve communication and patient care by using empathy. There is no shortage of literature about empathy. Some of it's good, some of it's bad. Not all of it has had rigorous scientific evaluation. So I'm going to try and take some of the more scientific studies on empathy, especially related to surgery, and present those for you today. But first, you have to start by defining empathy. And empathy is the ability to step into the shoes of someone else. And you understand their feelings and their perspectives, and then you use that to guide your care. It's quite different from sympathy or pity, which are feelings of sorrow for someone else's misfortune, feelings of compassion for someone else's plight. But again, this is the ability to understand, and it helps you change your own thoughts or what you might prescribe or do for a certain patient based on their own goals and treatment and their own life. It's been studied in many different areas. All of the solid lines are studies that have come out looking at clinical empathy and patient care. The dotted lines are areas where the literature is a little bit more fuzzy, but empathetic communication has been studied in terms of patients and how much they talk about their symptoms, how much detail clinicians can attain, and making accurate diagnoses. Patient perspectives, such as how the patient feels valued or validated. And the less fuzzy literature is really on short-term or long-term outcomes due to empathetic communication. If we look at empathy in surgery, this is a study that looked at health literacy and empathy in orthopedic patients. For those of you that are not familiar with the term of health literacy is a patient's ability to take information that you give them, assimilate it, and make positive changes in their own life. Smoking cessation is a good example. If you think people don't know that smoking is bad for them in this day and age, you're crazy. But how many people do we know that smoke? They obviously cannot change for one reason or the other, or choose not to change. So health literacy is the ability to make changes in your own health care. When you look at this green line and the blue line, those are represent patients who perceived that their caregiver was empathetic versus those that perceived that their caregiver was not empathetic. And they looked on the x-axis at information understanding. How much did the patient understand about the orthopedic procedure that they were going to have? And then their health literacy. And you can see that when there is an empathetic provider, they understand more and it does improve their health literacy. But there's a kind of a tipping point where patients may perceive their provider as sympathetic and may get focused and caught up in those perceptions and not get as much understanding and not change their health literacy. When we look at trauma patients, we have a ton of trauma patients here. When we look at empathy and the outcomes for trauma patients, on the left side of the screen, it shows the physician's empathy from a 10 to 50 point scale. This is a survey that was sent out. And then patient outcomes at 6 weeks and then at 12 months. And what you can see is that the more empathetic a provider was, the more or the better the patient outcomes were, both at 6 weeks and 12 months. And these are perceived outcomes from the patient, I have to say. And then patient or empathy and surgical satisfaction. Now I realize that patient satisfaction is kind of a hot topic, and not all of us are excited about how we are judged in terms of patient satisfaction. But the ability to be an empathetic provider does improve your surgical or patient satisfaction, and this is in hand surgery patients. So patients that had the care measure is a measure of empathy. Patients that seemed to do or thought that their providers were more empathetic had better outcomes. We get Press-Ganey scores, or we get health grades and different things. And sometimes what we see on those particular surveys can be disheartening to us. And we've discounted it at times. But the truth is that patient satisfaction is here to stay because it is entwined with some of the legislation that has come out. So the Consumer Assessment of Healthcare Providers and Systems is part of the Affordable Care Act. And what it is it's funded by Health and Human Services, and it promotes the assessment of a patient's experience within healthcare. So the Press-Ganey surveys that are sent out or that are done after patients are discharged or after clinic visits are part of this legislation that was mandated. There are many ways that you can do this, but the Press-Ganey system is the way that we do it. And the goal is to develop standardized surveys that allow us to publicize and compare our results from one hospital to the other. So it allows us to objectively compare on topics that are important to consumers. And we use public reporting to create this incentive to then improve the quality of care at the hospital and enhance accountability by increasing the transparency of hospitals and of providers. It's standardized. Again, we talked about it's one of the first national and standardized reporting systems. And now it is publicly reported by Medicare too. You can go to medicare.gov. You can look at yourself. You can look at the hospital and various programs. And the survey assesses various areas, or the requirements are that it assess various areas. Specifically, doctor communication, pain management, nursing communication, discharge communication, cleanliness. Was it quiet at night? You all see those red, the little stoplights on the ward. This is part of that, is to assess how loud it is in some way to improve whether or not it's quiet enough at night for patients to heal. So we're going to look at patients' perceptions of care at UCDAVIS. These are comments that are taken from our own Press-Ganey scores in the surgical arena. So these are from either Davis 11, Davis 12, or the inpatient, or the outpatient clinics, the Cypress Clinic or the vascular clinic, those areas. So when you look, and I have to, in all honesty, of informed consent, this is just like an informed consent. I'm going to tell you everything bad, and I'm not going to tell you some of the good stuff. So I've taken selective comments. Specifically, you can see here that in the positive, this is inpatient scores from Davis 11. The positive was the medical staff were excellent. I blacked out the names, but I will tell you that it's Dr. Utter. So Dr. Utter was fabulous, excellent. He made me laugh, which hurt, but that's my fault. But then there are some negatives. My discharge doctor was rude. She told me I could go to a shelter or find a ride home. That was the worst part of my stay. They used terms that I didn't understand. I was in a coma, so I didn't really know what was going on, and I had to rely on my husband for information. Very little time was spent with me by the physicians, and I could not say anything specific about them. I only saw one surgeon. The rest were all interns and residents. They have to learn that patients are human. The other one is, I don't even remember seeing a doctor. They may have come in, but I don't remember. Now, I guarantee you that every single day the patients see a doctor. And we've all heard sometimes when the female residents go in, they don't think that that's the doctor. They think that's the nurse or something along those lines. So how can you make it very clear when you go in who you are, what your role is, and that you are their physician, be it you're a man or a woman? This is another one that came from the clinic. There was a consultation. They were trying to help me decide about surgery. I asked a number of questions that were suggested by the brochure, and the doctor said I asked too many questions. They quoted me a price, but it was more than the former surgeon had quoted me, and he said it was because there were advanced techniques. My first doctor said I would only need local anesthetic, then the other doctor said I needed general anesthesia, and I asked if that was a problem, and finally he said, yeah, maybe it's a problem. Then I asked him about his training. He reacted as though he was insulted, went to the other side of the room. I would not feel comfortable using this provider. I'm going to go to a different surgeon. Additional things on doctor. This is my patient. God bless him. None of the doctors read the charts. I know where I took this from, and I know the patient. So no doctor at UCDAVIS ever reads the chart. I skipped the expletives this one time because we're in public. You guys are almost perfect, except you never read the chart. And it's funny because I've taken to explaining to my patients that I've looked through your chart, but there's so much information, it's hard for me to kind of figure it out. It's just a way to present to them. They think it's easy. Patients think that all the charts are connected. The VA chart is connected to the UCDAVIS chart, which is connected to everything. It's all connected. It's not. Shocking. They don't know that necessarily. They think we're magicians. Discharge communication. We talked about how that is one of the things that are captured. I had issues getting my pain medications from my pharmacy. I wish I'd been discharged with some medications. It seemed kind of vague. I lived 4 hours away, and it was really stressful. It was just, again, delayed because of medications. I wanted to stay one more day. I felt fairly constipated. I was very uncomfortable. All little things that we don't necessarily think of sometimes. In terms of clinical assessment, this is the ability to get into the clinic. This is from an outpatient survey from the Cypress Clinic. The phone lines are busy. I leave a message, but sometimes I don't get a reply back. The nurse, the bottom one is from the nurse. The nurse helped me 100% because the doctor was rushed and didn't take the time to answer my questions and didn't really seem to care about my condition. This is another kind of, these are all of the different spectrums from one particular clinic. They double book. Do you double book your clinics? They double book, and so the appointment the doctor runs in and out, and I didn't have time to get my questions answered. The nurse didn't fully explain what was going to happen with the doctor. They took pictures of me naked. That's something that we have to discuss. There was no warning that they were going to come in and take pictures. I felt violated. The hard part for most of us in this room is that people place more importance on the doctor's interpersonal skills than their medical judgment. We went to school for years to become competent, and you endure years of residency to become competent in your medical judgment. But rarely do we talk about interpersonal skills, and that is where you will be judged. And transparency is everywhere now. If you do not think so, you can go and look at yourself on vitals, health grades, consumer reports. Some initiatives that have been taken are actually health systems providing their own ratings of their providers because people will go onto the internet and find there are a lot of inaccuracies. There is no way for us as providers to police what are put on some of these other websites. So today we're going to talk about a model that has been developed to improve communication between you and your patients in order to improve patient satisfaction, improve understanding of disease. And that model is called the READY model. It was developed in the Cleveland Clinic. They have a Center for Health Experience, which is a center that's there to study the patient experience and also to come up with different methods for improving the patient experience. It focuses around, there are many different aspects to that experience model, and we are only going to look at one part of it today, which is the patient relationship or the READY model. So it starts with the relationship and then establishment, development, and engagement of the model. So relationship establishment. This is the R and the E of the model. The first thing that you want to do is convey the value of respect with the welcome. Most of us think we do that. I knock on the door. But other things that you can do are read the chart a little bit before you go in. And most of you try to do that, but yet sometimes there may be one or two things that you didn't see. Or do you tell the patient that you read the chart beforehand? A lot of times what I will say is, I saw that Dr. Moore sent you here to see me. How are you doing today? Or how are your legs feeling? I saw that Dr. Moore wanted me to see you for varicose veins. When you read the chart before going in, you really want to focus on their prior visits, any kind of new studies that they may have had. Know their referring provider's name, potentially. That's one area where that's their primary doctor. They've seen that doctor so many times, they may trust that doctor more. And that helps to establish that mutual respect as well as a value to the patient. Knock before entering, we said that. Use last names to convey respect. A lot of my patients call me Misty. The first couple of times it bothered me. I don't know that it bothers me anymore. I was Misty way before I was Dr. Humphries. And so, although my patients sometimes use my first name, I never use their first name. I tend to use their last name whenever I'm addressing them. Ask about additional people in the room. Are there 8 people in the room? Who are all these people? How are they related? One of the things I have had to get out of the habit of doing is say, oh, are you the wife? No, I'm the mother. Oh, whoops. Oh, I'm the daughter. Oh, okay. So I try to just say, and who are you now? Because I've really stepped in a number of times. Oh, are you her son? No, he's my husband. Okay. Woo, good for you. Wow. So try to be careful that you don't do a little something like that. Introduce the team. When I go in to see a patient after the resident has seen the patient, I try to remember to say, Dr. Park told me about your story a little bit, but I want to hear some from you. That also conveys respect to the resident and helps the patient see the resident as a physician rather than a trainee, which they are, but still. And then position yourself at eye level. Dr. Holcroft will tell you, sit down. Just sit down. Talk to the patient on their level. In terms of also relationship establishment, you want to collaboratively set the agenda for the visit. For those of us that work out, Zach Luzny, every workout has a purpose, correct? Be it that you are doing endurance training, which is like a 4-hour ride, or a long run, or whatever. Every workout has a purpose. Every visit that you see with the patient has a purpose. You need to set the agenda with the patient, and the patient needs to be on board. Now, the first thing it says here is, tell me what brings you in today. And if your patients are anything like the vascular patients, they have no clue. I don't know, my doctor sent me to see you. And that's okay, but you kind of have to redirect them a little bit. I see that Dr. Moore sent you to see me. Did he explain to you why he wanted you to see me? And he may not have. So it's important for you to kind of set that agenda and try to help them understand why they're there. That is going to help them retain more information at the end of the visit. One of the things that they taught us in this course, which scared the heck out of me at first, was they said, elicit the topics that the patient wants to cover. How many things might the patient want to cover? A lot of times if you tell them what they're here for, but then you ask them other things that may be bothering them. No, they may not be related to what they are seeing you for, but you may be able to help them in some way. For instance, a patient came in, he had had a stroke. He really just needed medical therapy. When he came back in to see me, I said, when are you seeing the neurologist again? I'm not. I don't have an appointment. They didn't help me set it up. I don't know. I said, I'll email your neurologist today and have them get you set back up. You send a quick staff message through the EMR. Next thing you know, the patient has an appointment. Or the patient comes in for a toe wound, but they've been having problems with their dialysis access. I see that you saw Dr. Perez and he did your access. Let me email his team and hopefully he can get you set up with something. You do have the ability to really change that patient's care through the system. Is there anything else that's bothering you that we should address? You elicit this list. So you're here, your doctor sent you to see me for your varicose veins, but what other things are going on that you want to address? Are you going to address all of them? No, most likely not. But the patient has been heard. Something that is important to them has been heard by you. And you may find a way to help them get that treatment they need. The big physician fears, just as some of the things I talked about. If you open the box of letting them talk, when you do open the box and you ask the patients to talk, how long do you think that we as physicians let patients talk before we ask a question? Anybody? Throw it out there. 20 seconds, 30 seconds. Dr. Weeman, your patient, huh? You got 30 seconds. So I guess, 18 to 23 seconds is about how long we let a patient speak before we interrupt them. How long do you think a patient would talk if we didn't interrupt them? 30 minutes. The average patient will talk about 90 seconds. 90 seconds is a really long time. If you want to start your watch right now and listen to me talk for 90 seconds, it's a really long time. But the reason to do that is because a lot of times what's bothering the patient the most may not come out in the first 23 seconds. The patient needs a little bit of time to open up to you. So letting them speak for a little longer than 23 seconds helps you to get the information you need to make your diagnosis. And the risks of not allowing patients to tell their stories are that the most important concern doesn't come out. 75% will never finish what they're going to say. And then 50% of your cases, you may have more difficulty making your diagnosis because you didn't hear what was one of the most important pieces of information. The other thing that most people said when we were in this course is, they're going to have so many complaints, and I don't want to hear about their hemorrhoid when they're here to see me for their carotid artery. Yeah, you're right. I'm not a hemorrhoid surgeon. I send them to see Dr. Vodofsky. He loves hemorrhoids from what I remember as a resident. But the truth is most patients have about 1.7 concerns. So it's kind of like when you have 2.3 kids. Who is that person with the 0.3 kids? But most of the time, they're not going to go on and on with things that aren't really relevant. Eliciting a list takes about 32 seconds, and it significantly reduces the frequency of questions at the door. Most other people said, well, it might take away from vitally assessing the chief complaint. The first concern may not be their main concern, though. And then you get this question at the doorknob that's really important to them, and you don't pay it as much time as the patient would like. And the perception when the patient leaves is, they didn't answer my question, even though you spent more time than you anticipated in the room. So when you are establishing the relationship, the mnemonic for that is SAVE. You use supportive language. I'm here for you. How can we work together? Acknowledge. If the patient's appointment was at 11 and you're seeing them at 11:45, I'm sorry that you had to wait. I had an emergency. Acknowledging their feelings. This must be really hard on you. Validating what they feel is another technique. Anyone in your position would feel this way. Allowing patients to realize that other people feel this way too is very important. All of us sometimes feel like we're the only one in residency that has to stay up all night and is going to go crazy. That's not true. At one point in time, all of us were going to go crazy in residency. And it doesn't always get better. I have recently been told by some of my senior faculty, I thought I was out. I'm a faculty. It's going to get better. And Dr. Pevick continuously reminds me that no, it's not going to get better. It just changes. It just changes in some way. Emotional naming, using words like you seem sad. So we talked about relationship establishment in terms of developing the relationship, which is typically done whenever you're doing the chief complaint, HPI, and the physical exam. You want to engage in reflective listening. This is very difficult. I believe this is very difficult for all of us in this room. I'm a fixer. I'm a surgeon. You come to me, I'm going to fix it. I take care of it. That's what we all do. So when people talk to me, sometimes I am listening to respond. My husband does this to me. I tell him, you will not believe what the GI doctor did today. They did a biopsy on a patient with Ogilvy's and they perfed the colon and it was crazy. He tries to fix it for me. How can he fix that? I don't want it. You don't need to fix it. I just want you to listen to me. Let your spouse, this is some relationship advice too. Let your spouse talk, just to let them talk. Try this whole reflective listening at home first, and then bring it on into the clinic and try it with your patients too. You want to listen to hear, not just to respond. Patients sometimes, they just want to talk for 90 seconds. That's all they're going to go. Elicit a patient narrative. Use some open-ended questions. And you want to explore the patient's perspective using the VIEW mnemonic. So VIEW is vital activities. This is sort of in the HPI, it's things we know. How does this disrupt your daily activity? How does your blood flow or your leg pain change how far you can walk? What can you not do that you want to do? Get an idea of what the patient thinks is going on. This was interesting to me, and I'll talk about it in the engagement portion too. But a lot of times patients have an idea of what they think it is. And you need to address that in order to steer them away from the wrong idea to the correct idea. Expectations. What do you think, or what are you hoping we can do for you today? You want to present it in a way that is not threatening. What outcome do you want to achieve with your treatment? We have a patient right now who has had multiple, I think she's on the trauma service, and many of you may know this, she's had multiple tumor resections. She's not doing very well. In general, she needs more therapy. She has an infected iliac graft. It needs to come out. Does she want to have another surgery? I'm not really sure right now. Our team, in fact, Meryl, is empathetically working through this with her to figure out what treatment she wants. Don't cry. Just because you're pregnant, don't cry. Worries. What is the patient worried about? Now, we've gone through establishment, development, and then finally we're going to talk about engaging the relationship. And this is the part where you can truly make a difference because it's at the end of the visit. The last thing the patient remembers is usually at the end of the visit. So, share diagnostic information from the patient's perspective. This is one of the things that I learned that's interesting because when I get to the end of varicose veins is something that I see a lot of in the outpatient setting, so I tend to reference that a lot, and I have a big spiel that I give patients because I already know what I'm going to say, I know what I'm going to do. What I started to do was ask the patient, what do you know about veins? A lot of them don't know anything. They take the blood to the feet. Well, actually, they don't. So I had to start at a very basic level. You need to speak at an 8th grade level. You cannot use big doctor words a lot of times. Even when I see somebody who is a nurse or a physician, I still give my spiel on vein disease or artery disease in the exact same way. And sometimes they're funny. They'll say, oh, I'm a nurse. You don't have to, or I'm a doctor, or I do this, or I'm a physical therapist. You can talk to me. I don't, because I want it to be exceptionally clear. I maybe change it a little bit, but I want it to be clear. Collaboratively develop a treatment plan. You need to find out what's important to the patient. You want to integrate that into a mutually agreeable plan. If the patient's goal is to never see a doctor again, when they come for their blood vessel disease, me doing an endovascular intervention is guaranteed they're going to come see me for the rest of their life, potentially. So maybe that's not what they want. They want to just be on some medication, walk it off, and go on about their day. Elicit potential treatment barriers. We had a patient who came in, operated on by one of my partners last week, came in, has a little bit of leaking from the groin, and I said, I want you to maybe come into the hospital if this continues because it might need to have something done. He said, I can't. He said, my kids are coming for Christmas. My wife is demented, and I can't leave her on her own. I said, okay, well then this is what we're going to do. And you're going to call me on Wednesday, and you're going to tell me that everything's okay. And we're going to talk this out through the phone, because that's what he needed. Provide closure. Affirm the patient's contributions. I'm glad you came in here today to get this taken care of. And arrange follow-up. In our clinic, there's a paper on the wall that says, before the patient leaves the room, put in what their follow-up is going to be. Because you want to make sure that they know when they're going to come back. And the last mnemonic is the relationship ARIA, which stands for assess, reflect, inform, and assess. And I have to say, I do not think the people in Cleveland are very creative, because they used assess twice here, but that's not the point of this talk either, is to criticize that. But assess. What do you know about veins? What do you know about varicose veins? What do you know about arteries? What do you know about the stomach, if you're going to do a stomach resection? Reflect. What worries you the most about this treatment? That's really important to get that from the patient. Visuals. The Crames books, phenomenal. I use them all the time. I circle in them. I put arrows to stuff for the patient. I give them the book home to go take that home. And understand their overall treatment and where it's going. Who are you going to talk about your treatment with when you go home? I saw a patient who needs a complete aortic replacement. She has a thoracoabdominal aneurysm from the subclavian all the way down to the bifurcation. She was told at another hospital, oh, we can do it. You know, she hadn't even had adequate imaging. We can take care of it. You're going to be fine. When she came to see me, I told her all the things she's not going to be fine about. You could be paralyzed. She's on home oxygen. You may never get off the vent. She recorded my talk with her so that she could take it home to her daughter, so that her daughter could understand. They made the decision not to have any treatment. That's a fine option for me, once she understood the risks. That's a way for patients to take that information, is let them use their smartphone to record what you're saying. How much information is forgotten by the end of the visit? What do you think? 40 to 80%. I've seen your notes. I've seen your I've seen your notes. They're extensive, on and on. 90% of that your patient doesn't even remember. And then how much of the information that is remembered is accurate? Less than 50%. Give them something to take home with. In the patient instructions portion of the EMR, when the after visit summary is printed, put one or two things. Wear compression stockings. I put that in my varicose vein one. A call to make your ultrasound appointment. I give them the phone number. It's in there. So we're going to finish with one more video.
I had heard what no woman ever wants to hear. You have breast cancer. And I remember sitting up and go, what did you just say? And she said, yeah, you have breast cancer. It's confirmed. I walked out of the breast center and I stood in the lobby going, oh my God, what the hell just happened?
I had a very uncommon occurrence when your pancreas explodes, as mine did. It felt like somebody cut me wide open and put a red hot
8th grade level.
in my abs. And that happened over minutes. I went from living my life to as about sick as a human being can be. Over the 4 months of hospitalization, I had 20 operations or major procedures. My wife literally camped out at my bedside every day because we didn't know if that was going to be the last day.
I had to have a CT of the abdomen. That's where they found out I had a mass on my kidney. I'm like, oh my God. Just to hear the word cancer can blow anyone away.
I was driving home. I didn't feel right. My car drove off the median, dropped about 30, 35 feet. I had a seizure, broke my back, sternum, ankle. A lot of things were broken.
I spent about 3.5 weeks unconscious and really had almost none of my major organs working. and yet I was hearing many conversations quite sharply. My family had 2 discussions about end-of-life care. I had the thought how interesting it was that I was watching myself die.
When I initially was diagnosed, how it was presented to me could have been maybe a softer touch. I mean, she scared me. I mean, it's scary stuff to begin with, but she knew I was alone. All I was worried about was living. I wanted to dance at my daughter's wedding. I wanted to hold my grandchildren.
Having that fear, not knowing what the outcome was going to be.
I was being sustained only by tube feeds. I was unable
Cleveland.
to eat. It was very difficult to do almost anything. So to be reduced to somebody who's essentially dependent on others for almost every facet of your activities of daily living is really difficult.
It's sort of a helpless feeling, especially when you're immobile. That's even more helpless because you really rely on them for everything. So having that one-on-one communication, because really you're waiting there and you're laying in that bed all day and all you want is 5 or 10 minutes. That's it.
So during my ICU stay, I lost 50 pounds. Every time that the nurses and others came to turn me, to change the sheets, clean me up, it felt as if my hips and my shoulders were coming out of joint. When you have completely lost your ability to care for yourself, you find yourself vulnerable and with limited dignity left.
Be kind to the person passing, walking a little slower than you. You don't really know what they're going through.
A lot of people tell me, oh, I know how it feels. You know what? Until you become a patient, no, you do not. Those feelings are entirely different. Yes, they are.
I could tell within seconds of a caregiver entering my room of whether they were in the moment and actually caring about me. It's a sense that you know if they're there to help.
Whether it's from holding their hand or patting them on the back. All those things end up being very important. Sicker you are, probably more important they are.
When I feel like I'm at the end of my rope sometimes during a busy day, and I try to put myself back in that bed. And then when I see somebody who might be angry, who might be frustrated, I remind myself what that feels like to be there. And then it makes sense.
So, over the last 2 years, I have spent more time in this hospital than I would care to as a patient caregiver. Many of you know my mother-in-law. Many of you took care of her. Dave Wisner, who accepted her whenever I called frantic because she was dying. Aaron Carr, when I met him, I think it was like one of his first times on call. I called him and I told him, you're taking my mother. This is what you're going to do for her. This is what I've already done. She'll be there in an hour. That was my introduction to him. He's like, who are you again? Danny Chang and Catherine Vu from Interventional Radiology, who performed 2 procedures that saved her life. The residents that took care of her, she remembers many of you. I slept in the ICU at her bedside the way I'd slept whenever I was a resident in the patient's bedside. My own mother was brought here, flown here from Texas to emergently have a cervical decompression by Eric Kleinberg when she was having intermittent bouts of paralysis. I slept on Davis 12 for 4 days. People would see me in the morning like in my pajamas. I was on call, and they'd be like, that's an interesting outfit. And then I would come back in scrubs. I would go down to the second floor, I would change, and I'd come back up and do my work. I know what it is like to sleep in a patient room next to a patient who cries all night, not my mother, but the other patient, because she was in pain. I remember how grateful I was when people helped my mother and my mother-in-law. It's a big deal. Empathy is definitely here to stay. It can affect your outcomes and your patient satisfaction. And there is a model of engagement, development, establishment, development, and engagement. And there are a few mnemonics here for you to use to hopefully help you remember one or two things from today. Thank you, and I'm happy to answer any questions.
Vascular surgeons need more empathy than others, but what a great, really a great way to help us enter this holiday season. So thank you very much for that. We do have some
that was a neat talk, Misty. You know, I think it's so important when you first meet a patient in the clinic, first visit, is to break the ice. You know, the first thing I do is not talk to them why they're here, their complaint, is to get to know them a bit. You know, in the military it's easy, in the VA, what branch of service you're in, where you come from, some world events, something. Just for the first sentence or two, just to show that you know this is a patient, and that goes as far as as you'd like, as far as off to the right foot. Oftentimes the patient comes in with issues. The resident sees a patient, they want their Percocet refill. No one's helped their chronic groin pain. It's not going to be easy sell just to kind of reassure them there's nothing going on. But before going in, that's the first thing I do, and then they seem to, the ice is broken, they seem to open up a bit more, then you can kind of go the direction that you like. So, wonderful talk.
Thank you. Thank you. Yes, sir.
Great talk, and this is without empathy, but the Cleveland Clinic videos made me think of this in patient perceptions. My uncle had his aortic valve replaced at Cleveland Clinic. He ended up with infected aortic valve, stroke, septic embolus to his brain with syringe and meant coil, and then eventually got a valve conduit replacement. Terrible outcome. My dad went to visit him at the Cleveland Clinic. I went back for all this. My dad went to visit him, and I said, "Wow, what a great place the Cleveland Clinic is." I said, "Why do you say that?" And I said, and he said, "Because they've got people in red jackets to show where to go."
Yeah.
And he said, "But Uncle Don ended up with infected aortic valve and stroke." And you get it.
Right. We get it.
That happens. So the patients don't care so much about quality of outcomes. They want to know how nicely they were treated. And so if you treat people nicely, they think you're a great hospital. I think we've got a lot more than that.
We have the ability to do both, I believe. We have phenomenal physicians here, absolutely world-class physicians. We deliver the best care in the world. Isn't that going to be our strategic plan? We are the best health system in the world. We are. Believe in yourself. But there are things we do need to do better. Tell people where to go. Everybody's lost in the hallway. Every time I see somebody lost in the hallway, where are you trying to go? Maybe I'm not the best. You go down to where the wall is, and you take a left, and then maybe you go to the right, and there's a really long hallway. But still, just for a second. We have people in blue vests now, or blue jackets. If you haven't seen them, we have blue jacket ambassadors. They have a blue jacket, they have a volunteer badge, they have a scarf around their neck or a tie. One of my patients' husbands is an ambassador, and so they help patients get around. They're phenomenal. But yes, it's not, as I said in the Wall Street quote, people don't necessarily remember the care, they remember their experience. Dr. Ali, you attended the seminar, didn't you?
Yes, I did, and I volunteered kind of when they first started the program when they came here. It's really valuable.
Yeah.
I'm just curious about your impression. First of all, I think this is phenomenal and really important stuff. We talk about team training and how we sort of own diseases and so forth, but we never talk about team training in this regard. Many years ago, a surgeon in private practice told me something that the light bulb just came on. He looked at me and said that the impression the patient has of me starts with the person that picks up the phone when they call for an appointment. So, what is the information and the data and the processes for making sure? So I've taken that to heart, and the people that work with me, I find you need to have the same type of mentality, interactions, and so forth. And so, what information is there that's available? Is this something that is being done so the team trains, who takes care of the patient, trains together so that the person who's talking on the phone, they're going to take care of the patient, the nurse coordinator, the practitioner, the dietitian, and obviously it's our program. How does that work?
Let me just tackle that for a minute, because there are two important things that are happening in the department that I think everybody needs to know about. One is that we are in the process of interviewing for a new practice manager and nurse manager for the clinics, but also as part of that job, I really want to sort of elevate that involvement around these kind of issues. And we've developed a new committee made up of mostly our younger faculty, really focusing on the marketing and the operations part to really address those exact things. How can we get this message all the way through our department organization so that that first impression, when the person picks up the phone, how can we provide concierge care, if you will, for all of our patients and make that happen for us? So I really welcome everybody's involvement in this process as we are right now interviewing people. I know some of you participated in that, and Misty as well as Aaron, a lot of folks are on this committee, and
young people
ideas that you have, we should bring to them.
But the other thing that just to go along with that, and what they did, the program that we went through in the Cleveland Clinic program, they made Cleveland Clinic made every single person in their hospital go through it. Every person, from the phone answer person to the dietitian. And they saw their patient satisfaction scores go from something like 52% to 92%, something crazy change. But everybody had to do it.
And it's a culture.
It's a culture.
The reason that I mentioned it is what came to my mind many years ago, almost a decade ago, is you sort of hear the patient say, "Oh, I have no problems with you.
Right.
I'm not talking about you. I'm talking about so-and-so." Like, wait a minute, so-and-so is
me.
And so it's a big deal.
Yeah.
Very big deal. Dr. Cabrera.
Just turn back to, you get a lot of these during residency, and you sort of chuckle and you think empathy should be something really natural. And even the first time I heard it, I thought it's a little bit insulting to give a mnemonic for empathy. It's really easy to be empathic with the patients that you are already empathic with. The mnemonic is for those patients that are really difficult to manage, or if they're addicts, if they're non-compliant, if you think it's a small thing, but for them it's a big thing. That's when you have to bring out the mnemonic and remind yourself to be empathic with those patients. But, having spent a year with you guys, you're all very nice and empathic with your patients, but it's that 5% of patients that you really actually need to sit down and before you get to all the medical stuff, why are you angry, you seem upset, you see, let's work out through the frustrations you have with our health system and actually get the help you need. That's where you need to remember the mnemonic.
That's a wonderful point. Thank you. Thank you. Yes, ma'am? Sorry.
So, as most of you know, my dad had to have a FemPop bypass last month, and because he signed his Medicare up to an HMO, Dr. Pedvick did not get the pleasure of operating on my 88-year-old father, so he had to go to Emory. And of course, he did his stress test and had to have 4 coronary stents, and I spent 5 days at Emory Hospital, which physically looks a lot like our tower. It's an old hospital. It's small, about 300 beds, but world-class physicians, just like we have here. And of course, I orchestrated every single piece and every single thing that happened. And they kept saying, well, we normally do this, but then there's you sitting here. But he actually did really well and got home. But as you sit there and watch an 88-year-old guy have all the interventions, I know he would have just died. So when I called him, I said, so will you take care of my dad? And he goes, sure. But I know when he put down the phone, he goes, oh boy. And my mother had an anomaly or aneurysm. I got to write about this, that had to be repaired at Hopkins. So vascular disease throughout. The key, I think, for us to even be better is this communication, this beautiful. But when you go out into the world, how do patients communicate with you? You only can control yourself. You've got your team. But every day is how you're going to control yourself. most physicians give out their cell phone number to every patient they see. Most physicians use their email, not only my chart. Most physicians now are letting them call right into you and you answer and you're so glad to hear from them. That is something we don't quite do here, and we need to change. Every day I talk to somebody on this phone. Some of them in my business, as you know, with TOS are a little off. But I think we really have to figure out what we can change and how to have that interaction. When you walk through the hallway and there's something on the floor, pick it up. You know, if there's a paper towel or debris, or someone lost, ask them where they can go. Smile at everybody and say good morning. Those kind of things you can do just immediately. And the kindness piece is just priceless to do that. I'm just so impressed you had this talk. And I think we can continue to communicate with people in a way that makes them feel better. Because I'll tell you, when my dad was there, I mean, I was the only one in my family that knew he was this close to death for 5 days. And because he shouldn't have been around. He should not be home. He should not be complaining to me like he didn't know about the bill and all that. He should be really sick. But part of it is world class. We are. So I appreciate all this input. But there's something you can do today that's going to be nice to somebody. And you just do it, you know, and especially the holiday, you know. One of my favorite times in the hospital is during the holiday. Because you're not in one of those beds. You're just on call, you know, and you're just doing cakes. You're not in one of those beds. And you didn't die on Christmas Eve like my one mother-in-law did. I mean, there's people that their lives have changed forever. So I love walking the halls around holiday time because it actually really does put it back into incredible perspective what we get to do. And I would tell you, give your cell phone to some patient today and see how good that feels. They're not going to call you, but they're going to have that number in case they're in trouble. And I've never had anybody who rang. But not patients.
Dr. Kokenar?
Ask for advice on trying to keep a smile on your face most of the time.
Yeah.
When you're trying to see good need.
Yeah.
More than 50 patients in a single day.
I don't know. That is where we have fallen down, I think. It's not possible. I talked to some of the residents. They have 47 patients on their service. That is unsafe. That is unprofessional. That is a problem. Though none of those patients are getting your time for what they really want. That has to change. I know there is a hope and a goal to change that, and there has been discussion of how to change it in your particular division, but it's going to have to change.
I think, just to follow up on that, there's a lot of tensions are high right now. There's a special meeting to talk about some of the issues that are happening in the operating room. Everybody's been feeling it. The hospital is as full as ever. And the difference about us being full now is that a lot of the processes to sort of squeeze the efficiency have been put into place. And we're still as full as ever. The OR is offering overtime to get more recovery room nurses. You've seen your patients being recovered in the operating room now. People are really working hard to figure out